All right, just want to make sure we actually recorded so we could get it on the cloud.
Yeah, no problem. I'm just gonna call Scott because he's gonna be tag teaming me because he's also a physician, and I'm just kind of wondering why he's
Got a
not.
couple people connecting right now through the waiting.
Oh, yeah, we'll just wait a little bit. Gotcha. Are you in? Okay. Do you have the right link? Scott's trying to get in. I can send it to you. Oh, I don't think you're in, hon.
Oh, right
Do you
now.
see him waiting?
There he is.
Okay, she found you. Okay, bye. Um, oh yeah, there he is. That's Scotty. Alrighty, I guess shall we get started, or do you see people?
Go ahead. I'm Nicole McLeod. I'm the upstate New York ambassador liaison for the Smira Foundation.
Progress.
Maggie. I hear a, sorry, I'm multitasking. I'm admitting everybody as I'm talking to you guys.
I'm sorry, you are. We can give them a minute to log on.
Sure. There we all of a sudden the waiting room was kind of flooded. I'm like, oh, let me click over here and click over there.
Oh, okay, no problem.
All right.
Okay, let's see.
Okay. So I'm Nicole McLeod, upstate New York ambassador for the Smira Foundation. Maggie has been doing this series and I've been to the first two. It was wonderful. I'm hoping a few more people pop on, but I'll let you introduce a little bit more about the series and yourself, Maggie.
Okay, great. So glad to see you all. Good morning on this Saturday. We're doing the third webinar of a three-part series that I'm doing for the Smira Foundation. And as many of you probably noticed in my Facebook video, that I am a physician by training and I'm a mom caregiver to my daughter Nell with a rare disease called neuromyelitis optica. And bringing the coaching concept into our family was really helpful to her in terms of her mental well-being support, as well as for our whole family. And that was the thinking behind bringing this coaching series to you all in the rare disease community. This specific webinar is going to be about how to be your best self-advocate in navigating the healthcare system. And before I get started, I also want to include an introduction of my husband, Scott Choi. It says Myung Choi over there. He's obviously Nell's father. We are both physicians and we've had a lot of interesting experiences navigating healthcare. And he will also be chiming in this webinar. Before I get started, I wanted to just acknowledge that it seems like a lot of people have had very negative experiences in healthcare, and that was the reason why I wanted to do this talk for you all. And people have described experiences of being gaslit and not being able to communicate well with their doctors. And so if this has happened to you, I understand. And to be honest, even as a physician, I have felt the same way. And I would recommend that you find your best fit doctor so you could feel seen and cared for. But if you can't find sort of like the perfect, or you have a less than perfect doctor in your local area, then I'm going to show you today how to be your best self-advocate and how to optimize your experiences and sort of review, the basic do's and don'ts. I also wanted to share that we are also in a similar situation where we don't feel like we're in sort of like the best perfect doctor situation in our area, but we are managing and have found ways to make it work. So the overview of this talk will be first that I will show you how to organize your medical data, like what's the most important thing and what is less important. Second, I will walk you through, oh, sorry, Nicole, maybe the next slide. Yeah, this is the title slide. And I went through that. And then the next one, here we go. So the second thing is that I will walk you through a standard way doctors document clinical information, so you'll understand how we think as doctors, and this will help you to have your conversation flow sort of more smoothly to optimize the exchange of information. And third, I'm going to discuss how the experience in the ER is different and how to leverage those interactions to be your best self-advocate and to increase the likelihood of your best medical outcome. So let's get started. Next slide. Okay, that is how to organize your medical information. So when Nell was first diagnosed and we were in the ER, I do have to admit that it was a lot of information. And even though I'm a doctor, when I left the hospital, I did feel like I had a whole binder's worth of stuff and I didn't know how to sort of take it to my next appointments. And so at first I had a written notebook, and that's fine if that works for you, but I found that going to a note-taking app on my phone was much more efficient because the phone is always with me. So I would recommend that. And even doing something basic like Google Docs, where you can organize into folders, works. I use something called Evernote, and I use their free version of that. And I think that that's essentially the same thing. But for me, it's just like visually more pleasing, and I can like see the folder tabs and click on them. So whatever way you could find on a note-taking app is what I would recommend. For pediatric patients, there's actually a note-taking app. Well, it's not a note-taking app. It's like an app called Mijo that's specifically created for pediatric patients with chronic and rare diseases. The creator is a father with a son with a rare disease. And I think that this app is great for pediatric patients because it not only covers your medical information, but you're able to input information about their personality so that when they go and see like a physical therapist or an art therapist, they already know a lot about your kid's personality. So in terms of information to scan into your app, you will probably have had a lot of clinical encounters in the hospital, the ERs, and maybe, consultation visits. The discharge summary is the most important document to have. I would not include the day-to-day progress notes or even like your journal notes. I would just include the discharge summaries because it's going to have the date, a summary of what happened in that clinical visit, the names of the doctors involved, obviously where you were, the medicines you were on, and their assessment and their plan will all be included in the discharge summary. So for you, you could pretty much get rid of everything else from that admission, but keep this. And other things are lab results and radiology reports. These are very important pieces of information. They will be included in the discharge summary for your hospital stay, but something like having a radiology report in a separate folder can be really helpful just to click on and access quickly if your doctor wants to know the result of the most recent MRI of your brain or your spinal cord and what those findings were. Similarly, for lab results, it's good to have that in a separate folder too, because your doctor can click on it and see kind of the trend of an abnormal lab that they may be following, as opposed to trying to search amongst many documents to find the lab result that occurred last year and compare it to the one that occurred today. Also, you will probably be talking to a lot of specialty doctors for consultation, and sometimes those doctors are not in the same institution. You might travel to see a doctor, maybe at the Mayo Clinic. So it's really important because that institution is not going to communicate with your local institution, most likely. And so you need to have that discharge summary or the consultation notes of that specialist's assessment and recommendation. So the name of that doctor, the date of the visit, the name and the name of the institution is going to be really helpful to, either your neurologist or whomever you're seeing at that particular time. So just a quick funny story I have to share. This is a very extreme example, but my friend who I trained with is actually a gastroenterologist in Manhattan, and he gets a lot of specialty consultations for, abdominal pain with no specific diagnosis. And this one patient came in with a binder this thick. And she opens it up on the first page. She says, I've seen 4 other doctors and here, Dr. blah, 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 and nobody could help me. So I'm here to see you. And I'm going to review with you day by day my whole journey on my symptoms. And he was like, no, this can't happen. So he closed the binder and told her very kindly that all those other doctors that she had seen are way smarter than him, and he doesn't think that he can do anything to help her. Like, that is exactly what his response was when he saw that and how she was approaching the clinical visit. So this is going to bring me to my second topic, which will actually be the bulk of my talk. And this is going to give you a window into seeing how doctors are thinking about the clinical visit. And I think that this is going to help you to optimize your experience in your clinical visit. So let's go to the next one. Nikki. Yeah. Oh, no, actually, no, that's good. That's perfect. So there is something called the SOAP note, which is a standardized way for all healthcare professionals to document patient encounters and clinical information. And we learn this as medical students. And this can sort of vary, and this is very bare bones, but I think it gives you a good insight into how we're thinking about things when we talk to you. And let's see, it's basically the anatomy of a clinical visit. And just to give you a perspective, when doctors see each patient, there's usually a huge amount of information and a lot of stories to kind of compile very neatly into an assessment during a very short amount of time. So the exchange of information should be efficient, and this is how to do it. The first part, if you go to the next slide, is the S, which is the subjective piece of the assessment. And this is all you, the patient, what you bring. And it's basically your experience. And let's say you're presenting with a certain symptom, like, headache or ongoing numbness or vomiting. And you need to, at this point, tell the doctor about that symptom. And specifically, you want to talk about what it is and where it is, when it started. Is it intermittent? Is it ongoing? What is the nature of that symptom? How often does it come up? Has it gotten better or worse over the last couple of weeks? And what makes it better and what makes it worse? That's the kind of key pieces of information your doctor's going to start using in their assessment. And what not to do at this point is don't give your own interpretation or what you think the diagnosis is, because that's too early in the stage, and that is actually your doctor's job. So allow your doctor to ask you all the questions about this symptom or problem that you're having so that they can get a complete understanding of what's going on. Next slide. O of the SOAP is the objective information. And in this section is going to be about the measurable data. And that can include things like your vital signs and your physical exam when you come in, and your labs and radiology reports. And so I forgot to also mention that in addition to the reports, if you can actually get a copy of your CD, a lot of times the neurologist can pull it up on their computer and they can see exactly what the abnormalities are. And it can be very helpful. And of course, the discharge summaries are really helpful because your doctor can just glance at the end of it and just see the overall plan from the previous visit. Medications, it's really important to know all the current dosing and when that medication was started, because sometimes the symptoms can be the result of a new medication or the interaction of a medication. So in order to sort out those differences, it's really important to have that objective data. And next slide, please. A is assessment in the SOAP. So in this section, this is pretty much all of your doctor's job. And so you can sit back at this point and listen, because your doctor is going to take the information you provided in the S and the O and compile it to form a diagnosis or an assessment of your condition. And so your doctor's going to bring their clinical judgment and all of their experience into play here and provide you with an understanding of what's going on. So when your doctor has given the assessment and the diagnosis, it is also your opportunity to ask questions and to clarify your understanding. Sometimes, medical jargon is used and you can ask, like, what does this word exactly mean? And this is also a really good opportunity for you to offer things like what you've learned at a patient day or recent articles that you have read about. And I think in the rare disease community, patients are very well informed about their disease. And this is a very good place to bring that information to your doctor to see if you can understand better what the current thinking is. And you might actually even bring something that your doctor didn't know to the table, and that can be really amazing. What I recommend you don't do is to share information from non-reputable sources like, Google searches or, information that you've heard from like your friends and family. Sometimes that kind of thing is not as helpful. So next slide. Yeah. Oh, okay. Let's see. Oh. Okay. Yep. I think I messed up that slide. We'll go back to that one after this. But the P is the plan in the SOAP. And so this is the part where your doctor is going to go through category by category the sort of issues or the problems that you're having and discuss a brief assessment and the plan going forward. So this, in my opinion, is when you really take part as an active participant and you use your note-taking out. This is what I do now. I didn't actually do this previously. I would just sit there and listen and think I understood everything, but then I came home and I would have all these other questions about how to do the details and the logistics of the follow-up. So I don't know if you guys feel the same way, but it really is a lot of information that we're managing as patients. So this is what Nell's plan typically looks like. And the first starts with the most sort of like the biggest plan, and you typically go down in priority. So her neuro/NMO, sometimes we go by systems or diagnoses, and they give this. The word stable is just kind of her general assessment very quickly. And then that she's tolerating her meds well, and that the plan is to continue her current satralizumab dose. So at this point, I would just say, well, that's great, but did you renew the prescription? Because this was a problem that just came up recently where I called the pharmacist to renew it, and they said, well, your doctor has not renewed the prescription, so now we don't have anything. So there was sort of a lapse in time before I could order it, because I had to call her office actually a couple of times for them to submit the prescription, the renewed prescription. So I think that's a good question to ask, because sometimes you're seeing this doctor once a year or maybe every 6 months, and you just need to make sure all of that is updated because your doctor may forget. And then the next piece is immunology, because Nell is on IVIG. And so, the doctor will say, well, she's doing well on that, but we're considering reducing her IVIG dose. Let's check labs at her next infusion. So before we move on, I would say, okay, stop. Did you put the lab requisition in there, and have you communicated that to our insurance company? Because that has to be given to my home health nurse. And that's all the planning her office side has to do by the time we get to the lab drawing. And with all labs, I always say, how and when will we follow up the results? Because sometimes we've had labs drawn and months will go by and nobody will reach out to us when we could have altered our management. And then the next issue typically is MRI, and it has been stable. And so they might say something like, let's follow up in a year. And so and a year is a long time. So for me, I have to make a mental note to, plan on that appointment. But when I make the appointment, they're going to ask me, is the requisition in? And so I'll have to call back her office and say, did you put the order in? So this is a really good time to say, okay, if you could put the order in today, I will call and make the appointment later today. And This is also a good opportunity, by the way, to find out, are we doing contrast or not? Because when I make the MRI appointment, that is often a question that I am asked. And I'm a radiologist, so I know the answer to that, but you should just know as a patient which body part is being scanned. Like, are you doing the brain and the spinal cord, or just the brain this time? And if you're doing it with or without contrast. Typically, it's with contrast, but they always ask at the time of the appointment. Neuropsych, because Nell's a student, is another issue that's on our list, because we have to get an appointment to have her neuropsych evaluation for school pretty much every year. And when that happens, our doctor has to give a referral and connect us with the neuropsychologist. Then I have to make the appointment, and then I have to follow up with the result, which then has to circle back to my neurologist, because she is the one that has to write the letter to the school. So all of these things have to get, put in place, and so that Nell could start school and the school will be prepared to support her. It's a lot. The final thing that's typically on her list is heme. That just means hematology. I just shortened that. And she's had some low iron issues. And so we've been checking her labs, and we're discussing her possible next IV iron infusion. And so once again, does she put the lab orders in? How do we follow up the lab results? And when we determine the plan? So when I am taking notes on the plan, these are all questions that I am now prepared to ask, because I include them in my own notes. So if we could just back up one slide, Nikki, I know this was put out of order. Yeah, that one. So all of the orange is the part that I am thinking about. All of these sort of italicized parts is how my doctor is talking to me and going down this list. So I would just recommend that you pull out your note at this point and start typing, so that you keep up with the plan and you ask the relevant questions, because this will save you a lot of time and trouble going forward. So maybe we could advance 2 slides, Nikki. Okay. This is my little story of the quarterback, because when Nell was first diagnosed, she had a number of issues, and we were talking to a lot of different doctors. We were talking to, let's see, neurology, hematology, radiology, and pulmonology, because she had an aspiration pneumonia. And there were various doctors in the ICU who were managing her at that time. So it seemed at first that her care was very sort of disparate, like everyone was managing her in their own sort of bubble, and it was very hard to coordinate the care. And so and a lot of times you will also have to play the role of the quarterback in coordinating all of the teams. I mean, all of the doctors from the various fields on a single team, to get them sort of, doing the same play to take care of you. Because even little things like medication, if one doctor's prescribing you medication, they don't know what the plan is with the pulmonologist, and you guys are both getting antibiotics, let's say from infectious disease and pulmonology, then that's not helpful, right? That's redundant, and it could possibly even be damaging. So that is the type of thing that you want. And then also you want to create the big picture. Like if neurology wants you to get an MRI, and let's say pulmonology wants an imaging study, you could potentially coordinate your visit to radiology on the same day. Similarly, with labs, you don't want to get stuff multiple times, right? So if immunology wants you to get labs, and let's say, pulmonology or infectious disease wants you to get labs, everyone should coordinate their lab submission at the same time, so that you can have your lab draw in that one event. So that's my tip on quarterback. And Scott, do you have anything to chime in on at this point? I don't think, do we hear you? Scott, I think on mute.
Oh, just wanted to introduce myself. Thank you, Nikki, for organizing this, and Smire Foundation, and Maggie. I think this is a really important topic. I'm a physician by training, like Maggie. I'm still in clinical practice, so I spend more than half my time interacting with patients in the hospital or in the office. So a lot of this stuff that Maggie speaks to is stuff that I've learned for many years as being a doctor, but also as being, the father to Nell. And my perspectives are definitely different than, before Nell's illness. So, I can appreciate a lot of the stuff that Maggie says. I think one of the things that Maggie and I talked about was what was an ideal patient interaction, what I would describe as being a great interaction versus one that's not so great. I'd say about 80% of the time, the interactions I have with patients are not ideal on many levels. And, 20% of the time they go smoothly, but I'd say 80% of the time they're not along the lines of what Maggie's talking about. So I can let Maggie take over, but I'm not sure if it helps to go through a scenario where I can give an example of a not so ideal patient interaction versus one that is better. What do you think? What do you think, Maggie? Should we do something like that?
Yeah, sure. Okay, let's do it.
I was going to give an example of what I do when I see a patient in the office or the ER or the hospital. And basically, I'm pretty open-ended when I walk in the room. I ask, why are you here? And, sometimes, I'll hear that the patient's there because their doctor sent them there, but they're not sure what's going on with me. They'll actually ask me a question in response rather than responding to my question. So they'll ask me, didn't you get my records already? I think I must have X, Y, and Z because I spoke with my family member who has the same symptoms. I tried X, Y, and Z, and I know something's wrong with me, but no one's been able to help me. I recently did not like so-and-so, so they treated me like a number, and now I'm here to see you. So the whole question of why you're here is not as simple, oh, I have NMO and I'm having a flare. I think I'm having a flare. It's an editorial on how you're feeling outside of your disease. So that alone takes up a lot of time. That's like 2 minutes or something where you're going back and forth with the patient and you still haven't answered the question. So if you answer the question, it's 10 seconds and then you get on to the next question. So, I would ask, how did this start or when did this start? I'm not sure, but you can take a look at my records. I have so much going on right now with my work and, my parent has been ill, so I haven't had really time to think about things, and it's been so hard. Plus, I've had to wait 3 months to see you. So, we get this a lot because healthcare is the way it is, but it's done nothing to help me as a physician know when your patient's symptoms started. So all you have to say is basically the date. Oh, it started on February 1st, 2023. And that's it, right? You've answered the question. So, so there's a time window in which we have as physicians to see you. So we really want to get through our questions as efficiently as possible. And oftentimes it's hard. And then, the next question may be, well, how often does this happen? And I'll get something like, but it happened yesterday. And I think it happened with my friend's birthday. When was my friend's birthday? I think it was 3 months ago. They were turning 50. So it's a lot of information that gets transferred to me that I don't really need. What I would say is an ideal response. Oh, it happens 2 to 3 times a week, 1 to 2 hours in the morning. And so, all my ideal responses take 5 to 10 seconds because you've kept track of these things and you're ready as a patient to talk to your physician about it. The other interaction can take 10 to 15 minutes, and oftentimes I have 30 minutes to see a patient. So I think it can be a lot more efficient than, sometimes it is. So I'll just leave it at that, and I'll let Maggie take over.
Thank you. Yeah. No, so I guess now we can move forward on how to be your best advocate in the ER. I'm going to finish at the end with some general coaching tips. And after that, I would like to take some time to answer some of these questions that I'm seeing in the chat. And if any of you guys would like to share some of your own stories or have questions, we will have time for that. So the third part here is about how to be your best advocate in the ER. Now, this scenario is different than your neurologist because you will have had a relationship with your neurologist if it's not your first time meeting them, obviously, and they will be very familiar with your rare disease. But when you present to the ER, this person, the ER doctor, does not know you and will most likely not know anything about your disease. And the reason is, just to give you a background, the ER docs in their training are focused on trauma and emergency, very common emergencies like appendicitis, heart attack, chest pain, and stroke that's more typical in like the elderly population. And so when they're presented with a rare disease in the ER, this is definitely not something that their training has equipped them to manage. So your role as a patient here is going to actually be very important because the disease that you share with your doctor could possibly be the first time that they hear about it. And they're going to give you a look like, oh my God, or they're going to be thinking, I don't know what to do. And so when you talk to your doctor, it would be really good to come in with information about your disease. And if you have the contact number of your neurologist or your primary specialist who has, medical background on your disease, it's sometimes helpful for the ER to just pick up the phone and talk to that person, and then everything is sort of illuminated in their mind. But just short of that, you should be prepared to give just a very calm elevator pitch, communicating the urgency of what you're presenting with, but in a calm manner, because it will allow the ER physician to sort of, trust you actually in knowing that you might actually know about your disease and get on board with a conversation with you about what to do. And let's see. It's also really helpful if, let's say, you're at an institution where they do have multiple specialists, for them to just call the neurology doctor on call. And I don't know, like people here may have different disease types, and maybe your specialty consultant is pulmonology or nephrology, but whoever that primary person is that is taking care of your specific rare disease, you might actually tell them in the ER that it's useful if you call this consult. And if you're at an academic setting, that consult doctor is going to be available 24 hours a day because they're going to have training fellows and residents. But if you're at a small local hospital, they may not have a training program. So in that case, I would actually highly recommend that when you're presenting with your problem and need to go to the ER, that you do it earlier in the day. Because if you go in the middle of the night, chances are that that specialist is not even in the hospital. And I don't know how long it's going to be for them to come and see you. And this is also really important that you have your note-taking app or a notebook where you have all the information, because the doctor is going to be asking you a whole bunch of questions. And it would be really good if you had them on hand to say, here's my last report. This is what they did at the last visit that I was in the ER, which it could have been at a different ER. And typically what happens is I get an MRI, I get steroids, because it's very important to sort of reduce the progression of, let's say, my blindness or paralysis. And in that case, when you frame it that way, your ER doctor is going to have a clear understanding as to the urgency of the problem. And that is actually their major role, to triage, to decide of the patients coming in, who needs emergency care, who needs to be admitted, and who needs to be discharged to home. So you want to make sure that you present your disease and the potential problems in a manner that your ER doctor can act appropriately in your favor. So let's see. Again, this is, you are going to be bringing your quarterback personality and style in this conversation, because in a lot of ways, you're actually going to be the person directing care, but you don't want to do it in a disrespectful manner or present yourself in a way where you're so frenzied and so stressed that your doctor doesn't feel that they can trust you. Because at this point, your doctors are probably not going to know. And that's the truth. I know that's not super comforting, but if you can guide them, that would be great. Let's see. So coaching tips. So next slide is this. General coaching tips on how to interact better with your doctors. I have a 3P recommendation. And I know I should have written that down, but I didn't. Let's see. So it's polite, prompt, and prepared. So this is just generally speaking. When you come in to any visit, so this is specifically to an office visit, actually, you want to come in, and actually in the ER too, you want to be polite to all the staff. Like the moment you walk into the door and the triage nurse is there and they may not be that nice, you want to still be polite. And the reason why is that this will actually get back to your doctor, especially if you're in an office setting and the doctors take care of their staff and they all work together as a team. If you're mean to any one member of the team, even though you have good reason, it can sometimes not play in your favor. And so I would just recommend that you try to be polite. I know it can be challenging because I've been there. And maybe just consider, if you want to be treated with a certain level of respect, to try and offer that to the other people when you enter their medical facility. Prompt is my next P. If you have an appointment, it is extremely important to show up on time, because you are demonstrating, once again, respect for the time of the office staff and for your doctor. And this is advantageous to you because you're not cutting in on the time that you have sort of reserved for yourself with the doctor and the staff in the office. In fact, come early. That way you don't come stressed. You can share your information while you're waiting in the waiting room. Just gather all of your information and actually kind of think about how you're going to organize what you're going to share. And 3 is P for prepared. And that's pretty much the same thing, is that in that O section of the objective data, you want to make sure that before you come into the appointment that you have all of this updated in your note-taking app, or you have just the original copies that you're willing to give to the office staff so that they can just kind of include it in your files. So I would say polite, prompt, and prepared is a really good way of thinking about how you enter any kind of medical setting to be your best self-advocate. And let's see, the other thing is, these are just sort of like random tips, but for pediatric patients, what I have learned with Nell is that in the hospital, there's often a lot of ways you can support your kid, and a lot of things that for some reason they don't share with you right out of the gate. And I found this out like on the 3rd or 4th admission, that there's a child life service that you can ask for that will talk to your kid about how not to be nervous about getting a needle stick, or what an MRI looks like, or just to kind of mentally prepare them for a plasmapheresis, things that are very kind of scary to anybody, really. And hospitals often have dogs. And if your kid is an animal person, this can be life-changing. And so I recommend that you get your kid on that dog waiting list, because there is sometimes one, and they have a certain schedule for the dogs to rotate through the hospital. And you want to make sure that your kid is available and awake for that dog visit. And art therapy, there's a lot of times art therapy in the hospital. I didn't learn about this, once again, until like our 4th or 5th admission. And it was only because I saw the art therapist moving her little cart around in the corridor. And I was like, what is this? My kid loves this. So I asked her to come and visit now. So for whatever reason, sometimes the medical staff and these other supportive groups are not always communicating. So it's really good for you to be proactive and ask, what are the ways I can support my kid in the hospital? Another thing I learned about that, I don't know if you guys know, is that oftentimes now hospitals have what's called a nurse navigator. And I did not know this existed, and they don't for some reason advertise it. But I heard that there was one at our children's hospital. And when she started to help us, she helped me to be the quarterback. And she helped to email the doctors and get everyone on the same page. And we were able to coordinate family meetings. And this was fully a game changer for us. So if you can have that opportunity to work with a nurse navigator, I would recommend it. Also, I didn't talk about MyChart. And I don't know if everybody has access to that, or I know we have some people overseas on this call, or, if you have any kind of ability by internet to communicate with your doctor in your doctor's office, that could actually be a really good way to start documenting information and scanning your files in And that could be really helpful because you don't have to waste your time at the doctor's visit to do it. It will all be uploaded in their system. So I recommend doing that as well. Now, I think that pretty much brings me to the end of my presentation, and wanted to first ask Scott if he had anything else he wanted to kind of share from his physician perspective as caring for patients. Because incidentally, by the way, I didn't tell you this, I am a radiologist, so I don't typically manage patients. And so I'm having Scott chime in for his clinical perspective.
Yeah, I would say that, our offices and our staff and our docs are all human. And so I'm very aware of medical inefficiencies and frustrations on the patient level about getting seen and having things done efficiently from our end. But I'd say we, for the most part, try our best, and we're only human. So I think what Maggie's stressing is for you to be your own best advocate and know your information better than anyone, and be prepared better than anyone. And don't take it personally if our offices aren't functioning the way that you like, because we're trying. It's sometimes very hard. And I would say that sometimes patients come in with expectation that I'm going to give them, or my colleagues are going to give them an answer in one appointment, but I'm just getting to know you. I'm just getting to meet you. So it's more of a client-based relationship that's going to extend over just that visit of 30 minutes. So I try to convey to my patients that, hey, I may not come up with an answer for you today, but I'm going to work with you to get there, and it may take some time. But I think sometimes expectation from a patient who's desperate to get healing is that they're going to get an answer that day. But I think it helps to know that you may not get an answer that day, but you want to put your best foot forward so the doctor can get you there. And don't take it personally if the doctor's saying they can't help you that day. It's not that we don't care. We're just trying to get you to that point. So I think managing expectations, but then becoming your best advocate, that's the message that I think is very important today.
Thank you. Oh, and that actually just reminded me of something I wanted to share too, is that I know that when we have bad encounters with doctors, and we have had that as well, it could be, your first response might be to feel resentful. That's of course totally natural, but also then to maybe consider it, putting that aside for a moment and think about what you want. This is what I do in the hospital. When I get into the hospital, I know exactly what I want. And I am trying to get everyone else on board to see what I want. And I have a belief that doctors, nearly all of them, did not go into the profession to give patients a hard time. I mean, I think that everyone I knew in my medical school class wanted to sincerely help patients, and that's why they went into medical school. And so when I remind myself and I get myself into that belief that I know they want to help me, it doesn't seem like it right now, but I know that they do. And I'm trying to appeal to that part of them by presenting my story in a way and asking them to help me. I have found that framing it that way and approaching my doctors in that manner is more effective, as opposed to me coming at them with my frustrations and complaining that they didn't, do rounds on time, or why they made this error, why they overlooked this, is sometimes, oftentimes, not helpful. So when I'm in the hospital and I'm very worried about what's going on with my kid, and I want the doctors to be on board with me, I have to think in a way that's going to bring them on board with me. I know that's kind of general, but maybe just kind of reframing your approach if you find that you're not getting what you want. I don't know how else to kind of clarify that, but I hope that's helpful, because I see Kayla here telling us that when she's seeing a triage nurse that you're in the process of going paralyzed from a rare neurological condition, they brush you off. Wow, that must be so incredibly frustrating, Kayla. I think with triage nurses, they're different than the doctors. I think that they are seeing a lot of people, and I don't know why they're not believing you. I'm sorry. I don't actually know exactly what to say to that. I don't actually know. Do you have anything, Scott?
I responded in the chat, actually. So I think one of the ways to try to be proactive in that situation is that you actually call your treating neurologist or specialist and have them call the ER in advance. They're not going to speak with the triage nurse, but they'll speak with the attending. And you can actually just say to the triage nurse, my neurologist has already called the attending of the ER. They're expecting that I'm here. So that gives you some legitimacy going into that discussion with someone who's really just trying to get the information down. You know, they're not so knowledgeable about you or your condition.
Yeah, I think that that is actually really helpful. I have done that before, and that also shortens my waiting time in the ER, by the way. So, okay. Did you want to say anything more to that, Kayla? Was that helpful? I don't know what she is.
Oh, it was actually me, Anne Marie.
Anything more, Kayla? Or was that not you? What were you saying?
Oh no, it was me, Anne Marie.
Oh.
Yeah, no, it was me. Yeah, I've been through that situation numerous times, and I've told them my doctor's expecting me, and you know they will say, you know, yada yada, and okay, we understand, and they still do their. I know you both know because you're doctors, but you know their priority list, doing their priorities, you know, with who needs to be seen first and yada yada. And you're still put pretty low on the totem pole. And I know it stings because there's really not a good, I don't know, way to present a sense of urgency to them that, okay, you know, I need to get in and get the MRI done. I need to get treated or else this is going to get bad. But yeah, it's just never a good situation. And I mean, I know we were kind of as a group with like the ambassadors trying to hopefully come up with like a protocol that we could present to people like, hey, this is what to expect. And you know, this is how you should look at patients.
Yeah, I think that this is such a challenging thing, and I don't want to bring in something here that's going to complicate the situation, but I do know that we, in our health equity conversations, also talk about bias, you know, for people of color and also for women. I don't know, like that specific conversation hasn't happened, but I am well aware of the bias of like women kind of presenting as like a little more crazy, and we're not given sort of the time that I think sometimes we should be given. I know I'm like talking about an area that's maybe controversial, but I wanted to just mention that in the situation because I think there's a tendency for some of the sort of the triage people and even physicians to some extent to think that women are a little hysterical, which is the reason why we talked about the elevator pitch. When you present your information, you don't want to convey that. And that's not to say that women are hysterical or that it's not appropriate to be hysterical if you're getting if you feel like you're paralyzed, because that's 100% normal. I'm just talking in the way of trying to get the other person on board with seeing the critical nature of your presentation. So I just want to make a side comment about that. I don't know if that's helpful, but yeah, I think bringing your doctors in advance of your presenting to the ER can be very powerful. Yeah, someone said I've been classed as neurotic. Yes. Oh my gosh. I do think we see this quite a bit. And I've actually seen that in like doctors' assessments that the patient seems neurotic, not like sure of what's going on. And I do think that there is that bias to label women as that. I fully recognize it. I understand that it's frustration, but I mean, it's frustrating, but I guess my thinking is I'm trying to figure out how to get around it. And I guess the way that I have figured it out, because I have been a hysterical mom, 100%. And I found that hasn't been like that helpful to me. So instead, I try to arm myself with information, medical knowledge. And obviously, when I tell people that I'm a doctor, it's helpful, but sometimes it's not. You know, they still think that I'm a hysterical mom, which I am, but I have, an urgent problem on my hands. So I know it's really hard to think when you're in this emotional situation, but just try and get yourself to the point of like, this is what I want. I need that doctor to understand. I need that nurse to understand where I am. This is the information I'm going to bring to the table, and, just kind of appeal to everyone's compassion and sort of logic. Let's see. Oh yeah. Has anybody had really good tips to share about what has worked with them in the ER?
I do. The last time that my son was admitted, I did actually what someone suggested, and had spoken with neurology prior, because he started having bladder symptoms that were completely not his norm. And he's autistic. So it's also, I think, around the time that he gets flares and whatnot, like he has the behavior aggressive side. So he refuses to go. So it's kind of like, okay, I'm going to try to get him there. I, am working up to that point. Sometimes I have to bribe him. But what was helpful was the doctor communicating with the neurology, person on call. They're like, I know who's going to be on call this weekend. And they had that, kind of prearranged. They knew to expect us hopefully within the next 4 days kind of thing, and plus we had to drive to a different city. And it was one of those wishy-washy things. At least once we got there, I was able to get that information and had the medication list and things like that. I recommend the website that you mentioned, the Miho, even for adults, just putting the medication list, some of those things right there. It's on a 2-page form, is really helpful, and the doctors and their phone numbers and all that stuff right there, because I never remember those things on the spot, especially when I'm nervous and anxious and there's a lot going on. And we'll still have where like the ER doctors, come in and evaluate, and they're like, they might, send you home since he seems to be feeling better now. It's like, my son always feels fine. He's autistic. He always feels fine, but he can't walk and he's wetting the bed, but he feels fine, so it's like, there's that side of it. But then once they communicated with neurology, they're like, no, we're admitting them. So,
Love that.
and then my son's like, but they said we're going home, so there's that side. But it's kind of like, that's just the initial ER people. But then once they communicated and I was impressed. I think we were back in a room within 3 to 4 hours. So, and that was our first good experience. And I think that approach before them knowing that we were coming helped with some of the urgency and speak up for us, because from medical trauma, I'm not the patient, I'm the mom, and I am absolutely traumatized by how we've been treated. So there's that side of it too, that aspect, so I can't imagine what it's like to be the patient in this situation. And it makes it harder when you're there trying to get help and, are dismissed, because you have all those experiences coming back as well. But that was, one thing that was helpful was connecting beforehand. And luckily that they, did communicate to them that we were coming.
Right. And I wonder, like in your last visit for your neurologist, I wonder if they can like print out a discharge summary, and can your neurologist actually type into the discharge summary like star, if this patient presents to the ER, this is what needs to be done, or something to that effect, and here is my phone number. Because if you have that piece of paper and you hand it to the ER with that part highlighted, I wonder if like in the event that your neurologist can't call or something, that can sort of act as your sort of neurologist recommendation. That just made me think about that. Also, Denise, I wanted to address your original question about how sometimes it's hard for some kids to express and diagnose their symptoms. Describe. So I could see how in your situation, if your child is autistic, that this could be extra challenging. And so obviously then you're the person that's going to describe what you have observed as changes in your son. But, I've seen like other scenarios where like you could use a doll maybe and just have your son point to the problem in that body and describe what's happening if they don't want to do it on their own body. Just something I'm thinking about, or a drawing, let's say. And I think in a situation like that, you could definitely call Child Life. They're very good at communicating with kids in a manner that's very different from a healthcare professional who presents as like more intimidating to a kid, and they can extract information a lot of times that maybe we can't. So I would say your role is very important. Ask Child Life and consider other ways of communicating. So I think we're nearly at the top of the hour. Does anybody have any other questions or anything that I didn't address in the chat?
He's been having his hand up for a while now, I think.
Yes.
No.
Oh my God, Martin, I'm sorry. Please
Yeah,
talk.
I'm here. It's the polite way to do it in Denmark. No, I think a lot of great points here. When Leda has some difficulties, we don't go to the ER. We go directly to the apartment who's specialized in this in the main hospital in Copenhagen. But a lot of the points that you're saying about being polite and everything, that's a good way to do it, because sometimes you are dealing with not even the doctors, you're dealing with other caretakers at the hospital and you can't get in contact with the doctors in any way. So what I've been doing a lot of time when I get really, really frustrated, I go over to them and say, I know that you are not in control and you are not able to do the things that I want to do, but I just want to tell you that I am really close to exploding now. So I hope you can help me before I explode. And that's a good way to contact them, because then they understand what you're saying. They understand the frustration that you're dealing with. And a lot of times they can pull a lot of weight other places at the apartment there. So I think that helps a lot. We've been working with Horizon in Dublin to make a toolkit. And a part of that toolkit, we'll be talking about if we need to make some folder, visiting card, something who makes in-flight on what is the difficulties with NMO that Leda is dealing with. So if we are traveling and we're going to a part where they don't know us, maybe another country or things like that, they can get a quick introduction to what they're dealing with. So that will fasten the intervention with them. So
I think those are all really good tips. I like the way you described how you interacted with the person, because you were still being respectful and you were being very honest about how you're going to maybe explode, but you don't actually explode on them. That's actually a very important difference. So
and make very sure and I make sure that I understand that we get it all the time. People phoning up if we're angry about our car, something like that. The guy that I'm talking with on the phone has no control on this. So if I start yelling and doing things like that, it's not going to help me in any way. Right. But telling him what is my problem, what do I need, that can help me in it. And that's what I think some people do in their frustration. They start yelling and getting impolite with persons who are really not in the position to make a decision that could help you.
Yes. I think you just gave a really good example of what I was describing before, is just trying to appeal to people's compassion. Because when you said that you're ready to explode and you're so worried about your wife, that person is someone they care about. And if this scenario happened to them, they would feel the same way. You're asking them for help in a respectful manner, but communicating your urgency at the same time. So I could see how you were very effective in that situation.
And it is the same thing. I know it's not the ER situation. It was when Leda was at the hospital too. She needed to get some tests done, and it was right around the corner, and we were waiting for days to do this test. And in the end, I went down there myself, and I said, I'm going to sit here, and I'm not going to move before. So, and I will come up every 10 minutes and ask how, and then she got an appointment half an hour later.
Oh, I love it. Yeah, you are actually bringing up another point that I wanted to make, but given our time, persistence is very important, especially in the inpatient setting. And if you guys have found this useful, maybe in the next talk, we could talk about inpatient experience. I did not talk about that because I think that was just kind of beyond the scope of what I wanted to present today, but you're right. In the hospital, when you're admitted, there's a lot of other things to sort of keep in mind to be your best advocate. So I think we're at the top of the hour. If I haven't answered all of your questions, feel free to email me. And I'm happy to sort of get on a call or just email you back, or however way I can support you the best. and maybe we'll do this again. So thank you to the Samara Foundation and everyone for being here on this Saturday morning. I hope you found this helpful. Bye, Leda. Thank you.
Everybody.